Welcome, everyone. This is Healthcare for All Washington. It's our second Wednesday speaker series. And tonight we're going to take a short trip along the Oregon Trail. Lewis and Clark are long gone, but John and Warren and Tom will be joining us from Oregon and will lead us on the modern portion of that trail. They'll recount the victories along the Oregon pathway to universal health care. Your job tonight is to help us move that trail or that pathway in Washington to help move forward, to help support the work we're doing with monitoring our commissions and boards and work groups and pushing our legislative action. My name is Ronnie Shure. I'm a retired pharmacist, and I volunteer as your president. You too can volunteer with Healthcare for All. Joining us tonight is your first step. We hope to inspire you tonight as we move forward. We hope to inspire you to join a committee or to help with some upcoming action. So we are posting a link to our donate button on the website in our chat. So if you go to the chat function, that you'll see that either Cello or Peter from our board will be entering the donate button, a link that you can just push on and then make a donation if you are able. You can also navigate to the volunteer section. There's a button that says get involved. And while you're on our website, of course, please make a donation if you are able, but we have also looked for that volunteering section. We've set a goal to raise $500 during our program tonight, so every little bit that you can donate does make a difference and does get us closer to universal health care. There also note that you can click a button that's at the bottom of your screen. You may have to hover over the bottom portion of your Zoom screen that says closed caption. If you click on that icon, then you'll be able to enable the captions to appear on your computer. Of course, Zoom doesn't always interpret things exactly the same way that we say it, so please watch those closely. So we're going to start our meeting with an acknowledgement of the people who originally settled the land that we live on today, long before Lewis and Clark even arrived in Oregon. And we stand on the shoulders of those original settlers. I'm participating in this Zoom meeting from the lands of the Coast Salish people. Please take a minute to acknowledge the peoples and the lands where you are. And we are expanding our territory tonight to include Oregon. We acknowledge all of the ancestral homelands and their traditional territories of indigenous peoples who have been here since time immemorial. Our efforts to achieve healthcare for all include universal healthcare coverage for Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations in Washington state, and the tribal nations of Oregon, the tribes, the confederacies in Burns Paiute and Coos, Lower Umpqua, the Siuslaw, the Grand Ronde, the Siletz, the Umatilla, Warm Springs, Coquel, and the Klamath tribal nations. So let me thank you again to everyone who has joined us tonight. And what I'd like to do now is to invite our three speakers, to invite John and Warren and Tom to join us on video to do an introduction. And let me pull everybody up. So there's John, there's Warren, and what have we done with you, Tom? We've hidden you somewhere. So there you are. So Tom and John, if you could just show your face for a brief moment. John is a retired primary care doctor and health administrator. He has policy experience in multiple organizational settings. He was a member of this Oregon Joint Task Force on Universal Health Care that we'll be talking about tonight. He's also a member of the Oregon Health Policy Board. Warren George is a retired aerospace plant manager and a business consultant. So he doesn't exactly fit in the mold of what you think would be the leader for a Lewis and Clark expedition or for universal health care. But he's been researching and speaking on designs for state and national universal healthcare funding systems for quite a while. He seems to be in every organization that I show up in. So it's a pleasure to have you. And Warren's not afraid to talk about the real issues in funding. Like you might even hear him use the word taxes tonight. We don't get to talk about that much in Washington State, but it's something we need to look at. He also was appointed by the governor to join the Oregon Joint Task Force on Universal Health Care. And the third visitor or speaker from Oregon tonight is Tom Sincic. He was a family nurse practitioner for 36 years. He served rural communities in East Tennessee. He served the Saginaw Chippewa tribe in Michigan. And then after Oregon, he was sent to prison. No, he worked with the corrections health program and with some school-based health clinics. And he's an adjunct faculty member at Oregon Health Sciences University, the School of Medicine, and at the Concordia School of Nursing. And his experiences as an advocate, I think, is what we will hear from Tom tonight. He ran as a state representative in Oregon and knocked on 13,000 doors to help lead the message on universal health care. He's the president of Healthcare for All Oregon, and he serves on the board of Nurses for Single Payer, a national group. So thank you to each of you for joining us tonight. And we're going to get started with John, and I'm going to pull up your slides. Is there anything that you want to say before we hide your picture, or should we go ahead with the slides?
Yep, let's go ahead with the slides.
Thanks, John.
Apologies that I don't have bandwidth when it comes to Zoom. I'm working on that. But you can hear me, I think, well, and let's go. Next slide. I want to start with some information you've seen in the past, the context that we've been working in. You know, transformation begins and builds and builds, and this work really builds on the kind of work that people like you all have done in the past. And so true for us. We were fortunate to have a Senate bill pass, Senate Bill 770 in the 2019 legislature that provides a pathway and inspiration, but also boundaries. The bill made it clear that what our focus should be when it came to universal health was a single payer. There were 13 of us on the task force. We worked our butts off, and we worked over 3 years. When you total up the time that we were involved, it's thousands of hours of person time and hundreds of hours of public discussion, public meetings, etc. We tried multiple different outreach efforts to get people involved. We had wonderful consultants and staff. I think we were able to come to consensus on multiple important recommendations that were really revealing in terms of what would happen if a single payer approach was pursued on state basis. We set up a model for folks to look at that envisioned implementation in 2026 that with a single payer would cost about $57 billion. Without a single payer would cost $58 billion. So I think we were pretty comfortable that this is going to save money. It's going to save resources for all of us. And that was with pretty conservative assumptions when it came to delivery system costs. We assumed they'd be the same. And modest, in my mind, probably overly conservative estimates when it comes to administrative savings. Next slide. So how were we able to do this? Well, as I said, we had a roadmap, Senate Bill 770. We had great staff and great consultants. COVID in some respects was a plus. A lot of us didn't have much else that we could do than work hard on this. And Zoom actually enabled us to get together, I think, more easily and quickly, and in many respects effectively. We did need to have our work extended. And again, the legislature stepped up and gave us more resources. We organized small groups to do much of the work so that we didn't need the big group to be doing everything. You just jumped back one. Go forward. And again. And we came to a consensus. That actuarial model stimulated questions, we answered them, and ultimately, it was difficult at times, we came to consensus. We had some challenges, but we moved past them. So where are we at today? Tomorrow, actually, there is a hearing, next slide, that in the Rules Committee of the Senate that will look at Senate Bill 1089 that does two important things. It creates a nonprofit public corporation with a founding board that's focused on actually doing this, on starting it up for implementation in 2026. That board will oversee a startup staff, the folks who will actually do it, and they will do these tasks that are listed here. I'm not going to go over these in detail because you could probably talk for 5 or 10 minutes about each one of these. But these, you can see this is a set of incredibly complex tasks. And that bill will give us until 2026 to develop this startup plan. Next slide. We've already learned some interesting things. A lot of discussion about, well, which agency should start this? Where will the founding of this be? We've ended up in the Department of Consumer and Business Services, the same agency that regulates insurers. I think that's going to be okay. The timeline, we kind of focused on 1-2-year period. Legislators felt we should have more time to do this. And so now, as I mentioned earlier, the bill funds the effort through one biennium and the start of the next one. We proposed initially that board members would be employed, hoping to really attract seasoned mid-career folks who would really have credibility at the board level and would really be committed. Legislators were uncomfortable with that. So we have a volunteer board in the current legislation that would get a per diem, it's modest. But we have a employed staff. And so now we're working on what should the budget be. And currently in the bill, it's at $3 to $4 million. We think it needs to be more in the $5 to $6 million range. We'll see how we do. There's some interesting context issues. We've learned, I think, as we discussed in a previous meeting, you have to be careful when you say universal health plan. That doesn't mean a single payer to many folks. And in fact, it's clear that we have many legislators in Oregon that vigorously support universal health plan strategies, but not single payer. And so again, it will be interesting to see how our effort navigates that. In this case, we're going to be in the executive branch. You know, we were in the legislative branch actually to do the task force work. The executive branch is the branch that gets things done. That is supposed to be good at getting things done. And my own sense is that's where this belongs. And it'll be interesting to see the degree to which our governor embraces this and emphasizes it. You know, one of the things we learned and are learning is when you talk about a startup team, you need experience and a mix of disciplines to make that work. And we're in the midst of trying to explain that to legislators as a basis for why we need more funding. And you need to have the right culture. You need to have a culture of transformation and adaptation and flexibility. You know, I recently watched Ted Lasso, and, you know, my last comment would be we need to create a culture that's more curious and less judgmental, and get everybody in Oregon to step back and really look at a single payer and what it could accomplish. With that, I'll pass it over to Warren.
Well, great introduction or great presentation, John. And this is the reason that we actually joke that we finally have a Santa that we can all believe in. So thanks for sharing that information. And let's move on to you, Warren.
Okay, let me. As John said, the SB 770 did mention single payer. After 3 years of discussion, the Oregon Task Force definitely recommended a single payer system instead of some other alternative like mandatory private insurance or public option. As a member of the Oregon Task Force, I will provide my own perspective of this decision. I've picked 5 major problems with which you are well familiar. Cost is at the top of the list because it's a big problem on its own, because of the high cost trickles down into a host of other problems. Perhaps worst of all our societal, for our societal future, employment-based nature of healthcare has been a significant factor in eliminating jobs for the lower middle class, creating a vicious cycle of escalating poverty. Ann Case and Nobel Prize winning economist Angus Deaton described the high cost and employer-based connection to healthcare as a wrecking ball, destroying the labor market for less educated workers and continuing to deaths and contributing to deaths of despair. No other country has placed such a high burden of healthcare cost on the decision to hire, automate, outsource, or eliminate jobs. And no other country has paid so dearly for this mistake. In the past few decades, about 15 million jobs, 7% of all employment by my calculation, has been replaced by contract workers who work for less and have no benefits. The big news story that everyone should be writing about and no one is writing about is that the bottom 40% of our population has lost about 1/3 of its income in the last few decades. Getting back to the general high cost, inflation adjusted dollars, we're paying about 10 times as much on healthcare as we used to, and about double that of other countries. Put matters in perspective. 1960, the worst thing that could happen to an individual cost about 5 years of our average per capita income. Now, the worst thing that could happen to an individual costs almost 50 times our per capita income. How can we deal with this situation rationally and compassionately? So how serious is our current predicament? Way worse than most people realize. Consider the 4 ways we can address high cost. There just aren't a lot of choices. We can spend more, each of us can spend more, including higher premiums, greater dependence on employers, greater government spending through taxes or deficit borrowing against future generations. We can transfer the cost, including shifting the cost onto the young, wealthy, and healthy, but these transfers are approaching their practical limits. And I can explain more about that in the Q&A if you like. Or we can deny or limit care, which is not very attractive. Trying to put it in the best positive terms, we can direct care dollars to where they would do the greatest long-term good, but it's a problem to be making those decisions. Or we can concentrate on becoming more efficient and more effective, which is, of course, where single payer shines. Mandating private insurance is a strategy based purely on spending more. The ACA, for example, transfers some additional responsibilities onto employers and governments, but basically the ACA attempts to solve issues of high cost by trying to outspend it. The ACA ensures that the spread between the US and other countries will only widen. As an additional example of transfers, used to be that medical care cost the same no matter who you were. But beginning a few decades ago, we have gradually split healthcare into a caste system where medical providers get paid a different amount depending on who the patient is. Using Oregon Task Force actuarial data, if the blue line is the average cost of providing medical care to a patient, Medicaid now pays just 69 cents on average in Oregon. Medicare pays 81 cents. Private insurance has gradually risen to $1.37 to make up the difference in declining Medicare and Medicaid reimbursements. Restricting reimbursements for Medicare and Medicaid has been like stepping on one end of a hot water bottle. You can make it go down on one end, but it goes up on the other. Our caste system can work in theory if everyone cooperates and all providers see about the same mix of patients, but it isn't happening that way. I'll give you some examples. Amazon just bought a multi-state chain of clinics, which are located in affluent neighborhoods with a high percentage of private insurance patients. Well, of course they did. On the other end of that spectrum, just yesterday, the Lund Report ran an article about Coos Bay Hospital, largest medical center in the Southern Oregon coast. Hospital is in default on its bank loan. If the bank calls the note, have to close, sell off the assets. Their problem is that only 17% of their patients are on private insurance, compared with about 60% in the Portland metropolitan area. Using a personal example of the difficulties caused by the caste system, in October, I received a letter from the Corvallis Clinic notifying me that the clinic could no longer continue to serve patients on Medicare at Medicare reimbursement rates. I have an appointment to meet a new PCP with a different clinic in 2025. Proponents of public options tell a narrative that public insurance company will be able to provide better benefits at lower cost. Therefore, we'd capture the insurance market, providing a long but relatively painless path to universal care. But if public options have such an advantage, why are there no successful examples of public options competing with private insurance? There is evidence of 3 reasons why public options fail. Governmentalization of insurance can provide savings, but really not very much. Another new option just adds overall complexity, which adds to the cost. And unequal distribution of high claims patients is normally what does in public options. Oregon's task force actuarial study estimated savings from a single payer system. These estimates fall in range with other actuarial studies. By far the greatest savings is reduction in provider administrative cost through virtual elimination of patient-by-patient billing. Of these savings, public option could only possibly benefit from the comparatively small savings from insurance margin. These savings would be reduced by the cost of state and administration and borrowing to fund the new public insurance company. Is the small potential savings of a public option enough to cover the added complexity of adding yet another billing system to the headache for providers? Study by the Colorado School of Public Health says no. Adding a new state payer in competition with all other available policies would actually increase the cost by 2 to 3%. Meanwhile, a true single payer system, once fully implemented, could reduce costs by 3 to 10%. Adding a public option makes the system more complicated and more costly overall until nearly 100% participation is achieved. A way to envision this effect is even if a small population is on each of 50 different insurance plans, medical providers need to maintain billing expertise and expensive software interface modules for each plan till the last patients have been converted onto the single payer plan. Proponents of public options would tell us that as we introduce public options, the savings just get better and better the more people can get signed up. But that is actually not what the actuarial evidence is telling us so far. The real killer of public options is the unequal distribution of high claims patients. Cost of healthcare is concentrated in relatively few people. In 2017, the top 1% of claims averaged 236,000, highest individual claims well into the millions. Takes about 400 people with almost no claims to equal one large claim. For insurance carriers, it almost doesn't matter what they charge in premiums. Their success or failure is highly dependent on who they insure. Consider for simplification that the bottom 80% of the population averages $2,400. The top 20% averages $44,000. When private insurance compete with a public option, all they need to do is shed 3% of high-cost patients onto the public option to lower their cost by 10% and raise the public option by 10%. As healthier people flock to the lower private premiums, public option premiums spiral up to the point of no return. For me, when you consider our dire situation and limited effectiveness of the alternatives, single payer can address the identified problems in ways that no other alternatives can come close. Single payer jumps straight over the concepts of risk pools and insurance policies, making them obsolete, while allowing medical resources to be directed where needed instead of where most profitable. Getting rid of our separate risk pools and insurance policies will require us to give up our false belief in individual cleverness, require us to recognize that our current protection of individual pockets of health advantage is a willful injury upon those whom we have been able to segregate into lesser care. Thank you.
So Warren, thank you so much for sharing that information, for your balanced perspective, and thanks to everyone for telling me that I was muted. So let's hide you for a little while, Warren. And before I bring up Tom Sincic, let me just remind you that we are entering the donate button in our website, or in our chat, I mean, and we also encourage you to enter questions into the chat. After Tom's presentation, we actually will start to answer some of those specific questions. But let me go ahead and bring Tom aboard wherever you are. There you are. And I will step out unless you want me to stay and read the questions on the polls. Do you want to do a brief introduction and then we'll start with polls, Tom? You too need to unmute yourself, but welcome.
There we go. Thank you very much for this opportunity. Thank you, John Santa and Warren George, for setting the stage, the next stage, and thank you, Ronnie, for setting this whole thing up. Basically, a correction for Oregon, and this talks to the issue of flexibility. There is no public hearing tomorrow on the bill because something has happened, right? So the issue of flexibility becomes really important. The public hearing has been postponed to an uncertain date. So that's it. And I would just say this: you've gotten the information at this point, from John and Warren, something about the task force, how it's been running. And Warren, the big thing is we've got to have single payer if we're going to have affordability and equity. He gave the data that showed that, right? So I think the thing here in talking to Ronnie is like, well, first of all, find out, who's out there today. I see there's 40 people on this thing, and I would love to find out like who's out there. And I think this first poll question, which is about belief in achieving, right? If we could just run that poll, we'll get an idea about where people are. Let's
So
just,
do you believe that we
can we just do number one first?
Yeah. So do you believe that we can achieve a single payer, publicly funded universal healthcare system here in Washington state? So the second question is, are you already volunteering with us? Have you participated in one of our committees? Have you completed the volunteer form on our website, but not participated yet? Are you more active in another advocacy group, a healthcare advocacy group, or more active in another social justice advocacy group? Or are you just too darn busy? So that's the second question. The third question we want you to answer is, what keeps you from participating? Not having enough time, the fact that we've never asked you to do something specific, not sure how, or you're already getting too many darn emails from people who are asking you to participate and you're feeling overloaded. The fourth, and I think that's the last question actually, is what would motivate you to volunteer? Either having, the clarity of our missions. We've certainly been working on that. Sending out email reminders, social media requests. Would the fact that the Washington State Legislature is doing some things, that we're seeing some victories, would that make you volunteer? If there was work in other states, would that make you volunteer? And what about in the U.S. Congress? It would be wonderful if things would be happening there. And would you like examples like we're supplying tonight of work in other states? So if you'll take one last peek at ending those polls, then we'll look at the results. So I think, Tom, you can see that.
Yeah, let's just do this one. Show up one at a time. We'll scroll down or scroll up. We'll start with that first question. I love that. This is a great place to start. So, and again, I don't think I can shrink it out for myself. So thank you very much. So we see, and seeing that poll, gets to the thing like, what does it take to win and get to where we've gotten in Oregon? The number one thing is hope that you can succeed. So the key here to advancing things in Washington state is to get as much hope in the group as you can, and get to not a sort of a marginal amount of hope, but a true hope of belief that you can succeed. So as we go forward, we have to see, is there something along the way as Washington state moves forward that would increase that number from 42% to 75%, right? Of people that are strongly agree that we can achieve. So it's basically, when we say hope, we don't mean some pie in the sky hope. We mean hope with determination that the job can be done. And that is, when I have the board meetings, I lead with that message, right? So that's kind of a key item to think of, what would it take for you to be more hopeful? We didn't get to that, but that's for you to think about, and for Ronnie to think about as you go forward in engaging people. Because when people are hopeful, they're more likely to be engaged. Okay, so when we go forward here, we want to think about addressing the problems that Warren showed, and what does it take? Well, John talked about the task force, but I want to talk about the background of this trail that's been taking place in Oregon. It didn't start with a task force in 2019. It started with the organization forming in the year 2000. So the trail was long. It's been long. And there's been some elements that have kind of come along the way that have changed the landscape. And part of this thing going forward was who are the people doing what? And what I try to bring into this work is organizing, right? And thinking about how are we going to move this thing forward? So when the bill to create the task force was formed in 2019, that bill started out as 82 pages. 82 pages to implement and create the universal healthcare plan. So what barriers did we have to overcome in order to do better than what we were doing, right? What was the things that were out there? Took some things, lessons learned from New York, insurance companies in the way, lessons learned from Vermont, the governor in the way, lessons learned from Colorado, not enough community involvement. So taking these things, that bill, which was introduced at 80 some pages, was dwindled down to 12 pages to do three things. One was to keep the insurance companies out of the picture. So if you have insurance companies in the picture, and we've had them in Oregon, and at the table, they're going to be in the way. So figuring out what can you all do to keep the insurance companies out on the sideline. Not that you can have a conversation with them, but not as a main thing, right? Secondly, we have a legislature that's pretty good. As John said, the legislature both gave us the task force, they renewed the timeline on the task force, they gave us a ballot measure to vote on a constitutional change, which we voted on, so we now have a constitutional right in Oregon in our favor. And so, and then the charge of the task force was clearly community engagement, community, what we call listening sessions. So that was kind of the key. And now going forward to this next step, it wasn't about, oh, the legislature is ready to do this. We had to find that true one legislative champion. So if there's somebody out there that knows how to find that person that is absolutely dedicated to this cause in your legislature and not distracted by anything else, that was a magic thing to have happen that we have in Oregon with Senator James Manning. So, and so those are the kind of things that can make a difference in your, so everything is by strategy. And so, and every step of the way, you have to think of what's a strategy today versus what was a strategy yesterday, what is a strategy tomorrow. And I like to do this in the area of game playing, right? And what is the specific tasks that people are capable of doing? What tasks are they willing to do? What do they have the time to do? And how do we assign those tasks out to each of those that are here that are interested in volunteering? So maybe let's look at that poll of how many people are already on this call, already volunteering in some capacity. I can't see the poll, so.
It's 33% participate in a committee or action. 8% of the people that are with us tonight, have completed the form, but are not yet participating. And another 33% or another third are involved in another healthcare advocacy group, and 4% in another social justice advocacy group, and 21% are just too busy at this time.
Okay, yeah. All right. So that has to do with when people say it's too busy, right? And what we don't know theoretically is that those people that are the busiest usually give more. So that's really an interesting, it's really an interesting thing. So think about what it would take for each of you. And I don't know if we can go to a full screen and I can see people's faces. I'm happy to do that versus my own face. And so I might be able to do that myself, actually. Nope, sorry.
Do gallery.
Gallery view. Yeah, that's good. All right, I like this better. We got some people out there and to kind of take a look at the faces, but it really is the piece of community engagement. So for instance, when we got this next bill passed, well, as we're getting this next bill passed, excuse me, we had over 300 pieces of people that testified in writing to the legislature. The normal high amount is 100. So what did it take? On the ground action, communicating with people and doing something. Literally not being in a meeting, but making phone calls and connecting with people. So, and having people basically tell their stories. We had over 50 people signed up for oral testimony. They couldn't get near to all of those people. But on the day 2 of the hearing, there was 28 people signed up in support and nobody signed up opposed, right? So that just tells us where we're at this stage of the game. So I'd like you all to think about is as you figure out about your own engagement, are people doing the same thing? We have some of that. People repeating and doing the same tasks, multiple people in the same room for the same reason, right? Now I go to John and sometimes Warren for conversation and to find out what is it that they think and will they carry something forward. So that is the kind of one of the key elements is to find out at any point in the thing, what game are we playing? This is about flexibility. So if you have a moment where, let's say a basketball game, you have a timeout that you can call and you can have a huddle. Now in that huddle, this is a problem sometimes in this world of organizing. There's a coach. The coach says, this is the next play. This is what we're going to do. Tell me how many people here, a hand raise, think that the player in the huddle should tell the coach, I think we should do something else right now. How many people here in this space think, oh, coach, I don't think we can win this game? Raise your hand if they do that in the huddle. So I suggest, as you're engaging, a lot of people are engaging, that you never cast doubt into your space because that builds energy. So if you cast doubt, it builds energy. Now let's take a different kind of a game. Let's take about the two. Yeah.
Tom, can we take a breath and do exactly what you're saying here and let people enter maybe some specific questions? But both for you and Warren.
Yeah, let's go.
John. And and I'd like to just take you off for a few minutes here and bring up another board member if I can. So Peter, if you could share, you could unmute yourself and let me find you. You are here somewhere. There you are. And while I'm doing this, if you could add any questions you have for Tom or John or Warren into the chat, Cello will start organizing those so that in just a few minutes we can dig back in and ask those questions. So Peter, why don't you tell us?
Okay, well, my role is fundraiser at this meeting. I want to thank our friends from Oregon for setting a great example and inspiring us. Back here in Washington, Healthcare for All has chalked up many legislative victories in Olympia, including helping to establish and appoint members to the Universal Healthcare Commission, which just convened, I think it was its 11th meeting this week. And we're hoping that this group could craft a publicly financed and will craft a publicly financed universal system based on our bill, the Washington Health Security Trust. But in order to maintain our momentum, it is vitally important that we meet with our legislators, grow our membership, educate the public, and mobilize our supporters to spread the word about universal health care to their family, friends, and most importantly, those in power in Olympia. We can achieve these goals through the hard work of our lobbyists and communications specialists, social media, monthly webinars, such as tonight's excellent presentation, meetings with civic groups, and by hosting other events. Financial support of our employees, as well as our other activities and obligations, all require funds, which is why we're asking you to donate tonight and every Wednesday on these webinars. Our goal is $500 tonight. Please go to the links in the chat or on our website and click on the donate button. You can make a one-time donation, but we would especially appreciate it if you can make monthly recurring donations to provide consistent support throughout the year. So please donate so we can spread the word and bring about universal publicly financed healthcare in Washington. That is the moral imperative. Thank you.
Thank you, Peter. So let me bring up Cello, another board member, and kind of take you down, Peter. And Cello, if you can start organizing the questions, I'm going to go ahead and bring up all three of our speakers. And let's see if you have some first messages or priorities that you've picked up.
Yes. So some of these questions have been answered in the chat, but I'm just restating them because not everybody here has read the chat. So I'm kind of going in order and just grouping. Craig Garver asked, is everyone included in your single payer plan? VA patients, Indians, Medicare, Medicaid with waivers. And this specifically is for all three of you.
Happy to answer the question. Basically, the plan calls for, if you look at our bill, it's SB 1089. There's a link to it, but you can look it up. Oregon SB 1089. Basically, everybody would be included, right? That's the plan. There is no plan yet. But the purposes, values, and principles of the bill call for everyone to be included. So it's as simple as that.
If I could add to Tom's remarks, the task force actually spent some time discussing eligibility, and we aimed at all residents. The originating bill actually said that we should include people who lived out of state but worked in the state. We decided that that was actually a problem because we were trying to get rid of the employment effect. So we actually dropped that. And this is actually quite relevant to the discussions of regional planning. In dropping people from out of states who commute into Oregon, we actually changed the cost structure by about 3%. Because if you remember my slide that showed some people paying $1.37 for their health care and other people paying 81 cents or 69 cents, suddenly we were eliminating a whole lot of healthy, high-paying workers from the system, where we could have just stuck Washington, taken them and stuck Washington with the Medicare and Medicaid recipients. It's actually an important issue. It's mostly resolved in the task force that all residents would be covered.
Anyone else chiming in, or may I go on to the next question, the next group of questions? So there are a group of questions about Medicaid, public and state employees, PEB, SEB, and ERISA, and I am just going to paraphrase them just for simplicity's sake. Wait, where's my little paraphrase? Jeepers creepers. Okay, what are the strategies for, what are your thoughts on the strategies for getting around the ERISA law? There was a huge issue in the 90s in Washington, and basically it sunk the whole plan.
Yeah, maybe I can just briefly, this is a very complex issue that deserves its own session. We had incredible consultants who have are nationally recognized for the work they're doing around the ERISA laws and different approaches to it. The strategy we have has multiple steps that they believe would eventually result in us navigating ERISA successfully, though it likely would be challenged in court. For example, they urge start with a benefit plan that the public employees have, not a private employer-oriented benefit plan. Start your focus on public employers since they're not covered by ERISA. And then acknowledge that ERISA does give self-insured employers some rights, and work with them on how to move around those issues. And it was one of the reasons why I really feel optimistic about this effort. I was impressed that, you know, it's like I said before, it's time to be curious about ERISA and less judgmental. People just assume, oh, it can't be done. No, I think it could be done. And somebody needs to try it and try it in a robust and credible way.
I'll jump in. This is kind of why we're at the next step. We're not at that step, to create this universal health plan governance board, because they're going to have the time and the staff to continue to look at, and you know, so the question is yet to be answered. It's being explored as to how, first of all, believe that we can get this done. And the next step in getting this done is go to, back to game playing, is to go to second base or third base and not try to hit the whole home run right now and, you know, and round the bases. So this governance board is our next step and strategy to make things happen. This is where these questions will be developed and answered fully and more, you know, more explored and answered to the best we can. So that's, and thanks John Santa for helping develop this.
Continue with the complexity. Roger, along with others, have asked, and I'm just going once again to paraphrase it using Roger's language. Transitional steps have been discussed both in Oregon and in Washington state. And as an initial transitional step, is Oregon considering consolidating Medicaid, PEB, SEB, and the exchanges? And would this demonstrate to Centers for Medicaid that the state has the ability to administer a single type payer program?
Yeah, if I could, since I sit on the Oregon Health Policy Board, let me assure you, Oregon already has all those included in one agency. It's called the Oregon Health Authority. The Oregon Health Authority does all those things, but it's incredibly complex to do them. And most of that complexity, I think, comes from the reality that it has to do everything through multiple payers. And that results in incredible variation. And you know, the OHA's goal is to eliminate health inequities by 2030. Good luck doing that in a multi-payer system, because so many inequities are built into employer-based health insurance and the quote competition that multiple payers have. As Warren said earlier, it's all about selection. It's all about getting the healthiest people. It's not about better care. It's about getting the healthiest people. And so we're already all combined up, but that's not going to solve this problem. The Oregon Health Authority has to eventually turn things over to a single payer.
And so, Cello, you should get this last question. We only have a couple of minutes left.
Yeah. So
and you
this is gonna be the last
volunteered
question.
to
Let me
organize
ask-
these for us. So why don't you
let me ask my last question, please. Which is my question, which I gave you guys a little bit of warning about. Could you please talk about your ideas on how we can redefine value-based purchasing?
If I can go first, value-based payments are really difficult to define, and so I venture a little bit into dangerous water here. But basically, I'm concerned. I mean, there's great value in doing some kind of payment system that rewards true benefits. So that is a good thing. From my own experience in business, I've never seen an incentive system that couldn't be co-opted by the participants. And so I'm very concerned about how that would be designed, and a little bit skeptical. But as long as it's done carefully, it could be a benefit. Just skeptical myself.
And you know, all I would say is, sadly, the concept of value-based purchasing has been ruined, I think, by for-profit, greedy companies who value to them means they make profits. And Medicare Advantage, as was referred to earlier when Warren described the session today, has become the most profitable insurance option for for-profit insurance companies. They love it because they can make huge profits from it, doing what they call value-based purchasing. I don't think that term's going to survive because of how inappropriately they've behaved. So we'll have to sit down and figure out what will work best in a single payer system that stresses cooperation and that we work together. And doesn't say, hey, you got to beat the other guy. You got to beat the guy down the block. You got to beat the guy in the other part of the state. Competition isn't working here.
As we're bleeding providers, as we're bleeding providers here, because they hate the system, right? What's of value to providers, and me being one of them, was just taking care of patients and taking away the burden of dealing with insurance companies, prior authorizations. That's what's of value to providers. They think there's some dollar incentive amount that's going to make a difference. We have a person that's just lost half of their clinical staff in a clinic because they can't take it anymore. They do not want to deal with the system. That's why I stopped practicing a few years ago as a nurse practitioner. So the issue is of value to who, right? And so that's the redefinition here. And get away to changing the focus of the discussion to make a difference, not to buy into the, you know, the
Well, let me, yeah, I think you've hit the nail on the head, Tom. So thank you so much. It's 8 o'clock. I want to thank John and Warren and Tom for reaching out to us and to participating in sharing their experiences. I want to thank the volunteers behind the scenes, to Rich and Cello and Sherry and Peter and DW, who's down there in Oregon now. And most of all, I want to thank each of you for joining us tonight. Please join us for our next discussion, which will be the second Wednesday in May, the 10th of May. But thank you all for joining us tonight. And thank you to each of you for being a part of this work. So good night.